Welcome to this Ortho-One Academy Symposia number 1. Dr. Sundaraj and myself are very happy to chair the next session. The very basic idea of this symposia has been stick to basics, because we found that a lot of youngsters wanted to switch to rotator cuff arthroscopic surgery, and they didn't know where to look for fundamentals. All the meetings, they go very high up in the beginning itself, and they don't get a chance to see the fundamentals. That's why we're having this particular session, and Dr. Sundarajan will introduce the speaker.
Thank you, sir. I request Dr. Munish Ashraf to speak about rotator cuff anatomy, portals, and positioning.
Okay. Good morning, sir. Thank you, organizers, for the opportunity. So today's first talk is about the basics on anatomy, portals, and positioning. So I would go across the talk through these headings about what are cables, crescents, suspension bridges, and intervals, scoping into the shoulder and placing in the shoulder. Now this is a rapid review was done up till 2023. Anything new I wanted to highlight? So anatomy, I wanted to discuss under the following headings: what we know, what we need to know, and what we must know. So that it's a bit more interesting. So the topics which we need to know are what is rotator cable and crescent, what is a rotator interval, how the insertion of cuff on the humeral head is, and something about pennation of the supraspinatus. So what we already know is the rotator cuff is comprised of 4 muscles: the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. Has a definite origin, insertion, action, and biomechanical role. This is the anterior aspect of the shoulder, showing the subscapularis inserting into the lesser tuberosity. It aids in internal rotation, and we also have the supraspinatus. This is the supraspinatus inserting into the GT, which aids in abduction. From the view from posteriorly has the infraspinatus and the teres minor. Both inserting into the greater tuberosity, aiding in external rotation. So what do we need to know? We need to know that the rotator cuff essentially condenses to form a avascular crescentric tissue near the insertion, and this avascular condensed tissue is subjected to microtrauma and more prone to traumatic tears. So there is a protective cable in front of it, and this description was done by Burkhardt in 1994. So this was called as a rotator cable, and the essential function of this rotator cable is to transfer the stress along and protect the inner avascular crescentric tissue. Now the journey of the rotator cuff or the rotator cable being called a suspension bridge was 60 years. It was Codman initially who described it in 1934. And he described this as an avascular crescentric tissue. Later Clark and Harriman proposed that it contained 5 different layers, and then it was Burkhardt in 1994 who proved it with his biomechanical studies that this particular tissue called the rotator cuff cable actually helps in shielding the forces from the crescentric tissue which is near the humeral head. So forces directed along the cuff goes into the cable and thereby protecting the avascular part, which is the rotator cuff crescent. The next concept is about the rotator interval. It is an interval between the supra and the subscap. It is made up of fibers from the SGHL, the superior glenohumeral ligament, as well as the coracohumeral ligament. This was described in 2002. The importance of the rotator interval is it provides function, it provides stability, especially the anterior glenohumeral translation. It is close by to the bicipital tendon, provides a landmark for the anterior portals. And then in adhesive capsulitis, it is one of the first structures to go in for synovitis. And during capsular release, this structure needs to be released as well. The next is on humeral insertion, how the cuff inserts into the greater tuberosity. These findings are by Mochizuki et al. It's a group from Japan. They have really phenomenal anatomical studies. So they have shown that the supra actually occupies a lesser surface area than the infraspinatus. Here we can see that the infraspinatus occupies at least 60 to 70% of the humeral head of the GT, whereas the supra contributes lesser than to the infraspinatus. Now this is a point to be remembered while repairing the cuff. A point on pennation angle. Pennation angle is nothing but the arrangement of the muscle fibers in accordance to the long axis of the supra. And in normal terms, the medial fibers have a 10-degree angulation and the lateral fibers have 85 degrees angulation. Now pennation, the more the angle, more the force, more the action of the muscle. So this is lost in retraction and fatty atrophy. The fibers are more parallel and hence can lose the capacity to bring out a force. So this fundamental concept is required to understand why retraction or fatty atrophy muscles do not exert the action. Now the biomechanical role of the cuff is a concavity compression principle. We have the anterior cuff, posterior cuff. It centralizes the humeral head into the glenoid joint, and we have the supra on top, which again prevents a superior migration. So this is a concavity compression principle, bringing the humeral head into the cavity. So next is we are scoping into the shoulder regarding the portals, demonstrated by Suji sir again. This is the usual positioning, surgeon and assistant on the side, monitor on the opposite, the scrub nurse and the table behind the surgeon. Superficial anatomy is marked, the clavicle, the distal end of clavicle, acromion and coracoid, bony landmarks marked. We have 3 basic portals and 4 accessory portals. The basic portals are posterior, anterior and lateral. Accessory portals will be the anterolateral, posterior lateral, Nevazier and the port of Wilmington. The posterior portal is a viewing portal. It is about 1.1 to 2 centimeters medial to the tip of acromion and directed towards a coracoid, the viewing portal. The structures at risk here are the suprascapular nerve. It's about 3 centimeters medial to the incision site. Anterior portals are usually marked when the scope is inside under guidance, anterior superior and anterior inferior. These are the working portals. The structures at risk here include the cephalic vein as well as the axillary nerve. The other standard portal is a lateral portal, which we can use for the viewing, 4 centimeters lateral to the acromion, and this should be in line with the posterior aspect of clavicle. Axillary portals are anterosuperior, the posterolateral, the Wilmington and the Nevazier portals. Out of all this, the posterolateral portal is important, can be used as a viewing portal to view the glenohumeral and subacromial space. So how to place the shoulder? There is no right way of doing it. There are lateral debicutus and Beecher position. Both have its pros and cons. The lateral debicutus is placed while the patient is laterally. It is the OT table is tilted 20 to 30 degrees to align the glenoid to the floor. Adequate padding is given and axillary roll. The traction should not be more than 8 kilograms. Beecher is more anatomic. The thorax is 70 to 80 degrees perpendicular to the floor, acromion parallel to the floor. It provides a more familiar view to the operating team, and an arm positioner can be used. The pros of lateral debicutus is that increased space with traction. Posteriorly it's free, there is no mechanical block, reduced risk of hypotension. In Beecher it's more anatomic, can convert to open if required, and regional anesthesia can be given. The cons of a lateral debicutus is that it's not anatomic, we need to reach out for the portals, repositioning is required if converting to open. For Beecher, mostly it's a mechanical block posteriorly. A risk of cerebral hypoperfusion is also there. The take-home message, a rapid review. Cuff anatomy is not about muscles, it's also about how we preserve the cables, understanding the role of crescent, what is the suspension bridge phenomenon, and also understanding where the rotator interval is. Insertion anatomy of the humerus of the cuff is different. Infra occupies more space than the supra. A pennation angle is a principle which we need to understand to identify fatty atrophy. There are standard portals, 3 standard portals and 4 auxiliary portals. You can add on extra portals depending on the case. And positioning, it's a matter of choice and training. There's no right or wrong, and it needs to be done on a case-to-case basis and discussed with the anesthetist priorly. Thank you. I thank Dr. David Rajan sir and Dr. Sham sir for providing me this opportunity. Thank you.
Thank you, Manish, for the elegant talk. As usually, always put things in the very simply and to the point. Would you like to come and sit with us so that the questions will be towards the end of the session?
Yeah, sure.
Please
sir.
come.
Sure. Sir.
So next.
The next speaker is Dr. Murugan. How to read the shoulder MRI. Dr. Murugan sir is one of the senior musculoskeletal radiologists. I think many of you may know him, but he is the first musculoskeletal radiologist in Coimbatore who revolutionized about all the knee and shoulder MRI, how to read that. Thank you, sir, for giving this talk.
My pleasure.
Just a word about Murugan, and I still remember those days when he used to come to Sita Lakshmi Hospital. Every time we do arthroscopy, he will come and watch, compare the MRI finding with the arthroscopy finding, and in the beginning, later on became a Pandit.
Definitely my acknowledgement to you, sir. And it has been actually my privilege to be associated with the Stalwarts because it helps me to, it has made me a better musculoskeletal radiologist by frequent follow-ups and gentle nudges now and then. It has definitely helped me to improve. So I'm really happy to be here. So in the next 10 minutes, we are going to discuss how to identify or detect a rotator cuff tear very early in a very simplified way, and also to identify the parameters which will help us to triage the patients, those patients who will benefit from surgery, so that we can tell them in advance about the prognosis based on the dash score and all those things. So that the ultimate aim is not to see patients at this stage. Okay. Now, this is how I look at the shoulder. First, axials. Forget whatever you have been, because generally the tendency is once we receive the films, we go for the coronal images, because that's the easiest to see. Please avoid that. Look at the axials first. I'll highlight it again and again. Then we have the coronal, which is along the plane of the muscle, and the sagittal, which are perpendicular to the muscle. And the go-to sequences are the T2 and T2 fat sat. They are the fluid sensitive sequences. Once you find fluid intensity within the tendon, that means there is a tear. Okay, I'll just rapidly. So this is the axial section. You can see the coracoid process, humeral head, and you can see the subscap tendon, infraspinatus tendon, and the biceps tendon. Okay, so the sagittal. So I'm going sequentially. First axial, then sagittal. You can see the muscle. This is a very good sequence to look at all the muscles and tendons. You can see as we go laterally, you can see the tendons inserting. All the tendons appear in one image. Then the last is the coronal. Okay, so don't go to the coronal first. Again, you can see the mid-coronal. We are able to see the supraspinatus tendon insertion. As we go more posteriorly, the infraspinatus tendon. So the summary is like this. So the tendons, because of the collagen content, appear dark. This is a take-home message. Should appear dark on all the sequences, whether it's T1 or T2 or whatever. So this is a take-home message. And of course, these are all T2 images, T2 and T2 fat sat. So you can see the dark appearing tendons. Same, whatever I have shown earlier. Again, I want to highlight how the sagittal is helpful, because you have to know whether it's isolated supraspinatus or infraspinatus. Only sagittal images will be helpful. So how do we identify abnormality? As I said, the tendon should appear dark, but what happens is, invariably in T1 images, the tendon will appear slightly brighter, or rather hyperintense. Don't get confused. Look at the T2. As long as the surgeons are concerned, unless you see bright signal in T2, it is not a tear. So it could be tendinous. I'll show some examples. For example, this is a T1 and T2. We can see the tendon is not dark, okay? But in T2, it is not really bright as fluid. So this is mild tendinosis. Again, one more grade. You can see again the tendon is not dark, but even on T2, it is slightly bright, but it's not as bright as the fluid. Okay, this is the fluid in subdeltoid bursa. In fact, this patient has got all the features of impingement, though impingement is a clinical diagnosis, not an MRI diagnosis. You can see bursitis, you can see AC joint arthropathy and subacromial spur all. But still, there is no fluid signal within the tendon. Coming to tear, of course, we know that's partial and full thickness. Most of the tears are articular surface. Less common is bursal surface and intrasubstance. Now, now we come to the actual interpretation. Okay, so we see this. This is a coronal image. This is a sagittal image. You can see that there is a fluid intensity. It is not extending to the bursal surface. So this is a classical rim rent or pasta lesion, partial articular surface tendon avulsion or rim rent. Typically, it is one of the commonly missed tears on MRI also, because unless we see the anterior and distal most portion, you can find a subtle hyperintensity You know, sometimes it would be difficult in the film, but in the monitor it's very easy. Ultrasound also, those who are doing ultrasound, we have to go really front and then the lateral to pick up the small partial tear. Arthrogram is less often being used, especially with cuff tear, but definitely it has got a role. In partial tear, for example, this was done, of course, for quite some time. We have not been doing arthrogram for want of the time and the patient throughput. But this was done for a slab. You can see a slab, but also this was a doubt whether it was a partial thickness or full thickness. But the contrast remains within the. So this is a high-grade partial thickness articular surface tear, not a full thickness tear. And delaminated tear, this is where the difficulty is, especially when it is a chronic delaminated tear. What happens is sometimes the fibrous tissue goes underneath the tendon and it will look, apparently it will be continuous. But if you see carefully, so this is the deltoid, this is some fluid in the subdural bursa, but the tendon is only this part and it is retracted. You can still see the tendon, the bursal part, but this is delamination, this retraction proximally. So that is something which is sometimes difficult, especially in chronic. So please compare the normal tendon. See, normal tendon should be at least 6 mm thickness. Whereas here we are able to see a thin tendon and it says retracted. This is one of the commonly missed tears. Full thickness. So when do we say full thickness? This is again some confusion. Sometimes full thickness, some of the colleagues sometimes mistakenly they feel it is the width, the anterior posterior. It's not so. It is the extend from articular to bursal surface. It could be a very small full thickness, even less than 1 centimeter. As long as it involves the bursal and articular surface, it's a full thickness. So various grades. Okay, again, axial. I have borrowed one of the topics from the next slide. Axial, I want to really highlight, because I have made mistakes, missed isolated subscap tendon tear by directly going for the coronal. Many a time, we'll have to be very careful. The clue is, in addition to the boss, we'll have to look at the secretary also. So invariably you will find the biceps tendon, is slightly slipping out. In fact, that is the clue. Many a time it will not be very obvious, but once you see the biceps tendon slipping out, then you know that associated subscap tendon tear is there. This is a classical supraspinatus tendon tear, illustrative case. You can see this is a coronal image. This is the retraction or length, and this is the width of the tear which is measured in the sagittal. Okay, now what to look for? The next part, we have covered the basic part. The next one is, which will be very useful for you from the surgical point of view. What do we look for in a rotator cuff tear? And what are the parameters? One is the tear width, retraction, how much it is retracted. What is the quality of tendon, muscle atrophy, and fat infiltration. In fact, this is an excellent article in Radiology. They have compared the preoperative MRI shouldering with the DASH score 1 year later, and they have concluded that larger the tendon, more retraction and more severe tendon degeneration, worse will be the DASH score. Okay, so how do we measure the width? This is the sagittal image. Okay, sagittal means perpendicular to the muscle. You can see this is the tear defect and this is the width of the tear. Okay, and generally more than 2.5 centimeter width means there is involvement of additional tendon, infraspinatus also. That is my personal view. And retraction is measured in the coronal. You can see it is retracted almost up to the glenoid. I have 1 more minute. Yes. So quality of tendon, again T2 images. You can see tendon is remaining dark on T2, so fairly good. Slightly brighter and more brighter. So this is the grade 3, more degeneration. Atrophy, you can just, in the sagittal, this is the importance of T1 images. T1 image is very useful to look at the muscle and fat infiltration. So we do this routine sagittal T1, draw a line from the upper body and to the spine of scapula. If the muscle extends above, generally there is no atrophy, so grade 0. Once it is flush, it is grade 1. If it is below, divide into 2 parts. If it is more than 50%, it is grade 2. Even if it is coming below in the lower half, it is grade 3. Another method is you can draw a circle in the supraspinatus fossa and find out the percentage. Less than 40 is severe, 40 to 60 is moderate, more than 60 is normal. Okay, coming to fat infiltration, I think last 2 slides. Again, T1 images, you can start from here. Grade 4, there is more fat than muscle. In grade 3, there is equal fat. Fat appears bright on T1. So that is how, all these white streaks are fat. So this is equal fat and muscle, grade 3. Grade 2 is some streaks and grade 1 is minimal. This is how we assess muscle, fat infiltration. So finally, the report is given like this in a simplified manner after describing everything. This is the, probably if you look at this, it shows everything. The muscle involved, the width, the retraction, the tendon degeneration, atrophy, etc. So I want to have a self-assessment. Can anyone make out the pathology here? Can anyone? 15 seconds. Sorry? Ah, that's right. Somebody has picked up the secretary. That's well. So you see, the tendon is missing here. Biceps tendon slip and the subscap tendon tear. This is one of the commonly missed. Even radiologically, it's commonly missed. So keep an eye on this. And so to summarize, don't forget the axial. Look for fluid intensity within the tendon on T2 images. Decide whether it's partial full thickness, the number of tendons involved, and then finally the retraction, width, tendon degeneration, atrophy, etc. Thank you.
Thank you, Dr. Murugan. Another excellent talk as usual. Would you like to come and sit here?
Yes.
We can face the questions a little later. If you want to treat shoulder, you have to know how to read the MRI, basic. The next we have who? Dr. Siddharth, who is going to speak on ideal anesthetic technique and indication. He's an anesthesiologist.
Good morning, one and all. I thank the organizing team for giving me this opportunity. And today I'll be talking about the ideal anesthetic technique and indications in rotator cuff injury. So the agenda will be the role of the anesthesiologist, then the role of the surgeon, and then the recent advances. So why is shoulder surgery very important? Any injury to the shoulder is considered extremely painful. Even in literature, it is described as being more painful than even that of a thoracotomy. This is because of the extensive innervation of the joint, which follows the Hilton's law that any nerve that crosses a joint will supply the muscles, tendons, and the joint itself. And also it is rich of alpha fibers, A alpha fibers, A delta fibers, and C fibers, which are very poorly responsive to opioids. So when it comes to rotator cuff, what we look at is the age group of the patient, the cause of the rotator cuff tear, the comorbidities, and psychological preparation of the patient. When it comes to the anesthesia aspect, we have a whole arsenal of skills at our disposal. The three pillars of being general anesthesia, regional anesthesia with sedation, without sedation, and combined general anesthesia. So why we prefer regional anesthesia is because it reduces the operating time, there's an early recovery, there's reduced post-operative pain, nausea, vomiting, and reduced hospital stay as such. So before we go into the actual block per se, you need to know about the basic anatomy of the nerve supply of the shoulder. As you can see from this slide, you can see that the shoulder main nerve supply are the C5, C6, and C7 nerve. And the joint is mainly supplied by the supraclavicular, axillary, and the suprascapular nerve. So if you are able to knock out these nerves, it will provide you with adequate anesthesia and analgesia. So the technique that we usually prefer is the interscalene block, which was first described by Dr. Vinny in 1970, where he developed the block by a landmark technique where we give a local anesthetic in the interscalene groove to block out the C5, C6, and C7 nerve, which was later more done precisely using the nerve stimulator and with subsequently with ultrasound. But the main drawback is at the level of the C5, C6, and C7 nerve, the phrenic nerve is in close proximity to it. So you 100% of the time mostly you will knock out the phrenic nerve, leading on to hemidiaphragmatic paresis. So this becomes a problem in patients who have COPD or who have athletic lung disease or in the geriatric age group. So then what do you go on to? So this is one article which was published in 2014 by Dr. Vincent Chang and Keijin Chin, where they suggested an alternative to the interscalene block, which is called the superior nerve trunk block. The basic is very simple. At the level of the nerve root, the phrenic nerve is closer to the C5, C6, C7. But at the level of the superior trunk, the phrenic nerve is away from it. So you will be able to knock out the nerves that are supplying the shoulder and at the same time prevent the hemidiaphragmatic paresis that occurs in the interscalene block. So as you can see here, you can see the C5, C6, C7 nerve that is closer to the phrenic nerve, but at the level of the superior trunk, it is wider away. In this slide, you can see that the gold standard of the shoulder surgery is considered to be the interscalene block, but the chances of the hemidiaphragmatic paralysis are about 100%. But whereas in upper nerve trunk block, it is only 5%, and it is in no way inferior to superior nerve trunk, to interscalene block when it comes to pain relief. So this is the classical traffic light signal sign which you see in an interscalene block between the two interscalene muscles, and the phrenic nerve is in close proximity to it. In this slide, you can actually see how we trace it. So from the level of the interscalene, we keep the probe down, you move it down and see the C5 and C6 forming the upper trunk. And you can see the suprascapular nerve taking off from the lateral aspect. This is the region where you need to put the block. So what is the role of a surgeon when it comes to arthroscopic surgeon? So it was beautifully described by Dr. Munish Ashraf in the previous slide. Mainly we look at the type of surgery, open or arthroscopy. Then we look at the port sites and then at the positioning. As far as positioning is concerned, in terms of anesthesia, the lateral position, we are worried about the traction on the nerve trunk, and in case of an emergency, it will become difficult for us to access the airway. Whereas in the supine position, we have easy access to the airway, but it can cause cerebral hypoperfusion, which can result in a neurological insult to the patient if the mean arterial pressure is not maintained properly. In abroad countries, they also go as far as measuring the NIRS in patients, which will give us a baseline about the cerebral oxygenation, and we'll be able to pick up any cerebral perfusion pressure drop immediately. So post-operatively, what are the challenges that you face is inadequate pain control, complex regional pain syndrome, and the need for planned rehabilitation. So the mainstay of post-operative analgesia is basically NSAIDs, opioids and non-opioids, and now we are also going into regional anesthesia techniques. So a recent advance which you can see in the regional anesthesia technique is, just like how you are giving a block, you can also put a catheter in the region of interest, and you can give low dose local anesthetic infusion. So this will aid in blocking out the sensory system but keeping the motor system intact. So this will aid in you being able to rehabilitate the patient faster. Second is, this is a drug new in the market. It's called liposomal bupivacaine. The major advantage of this drug is that it acts for 72 hours. So a single block can work on for 72 hours and give you excellent post-operative and intraoperative pain relief and analgesia. But the only problem is, right now it is extremely costly. 10 ml is 35,000 rupees right now. So this might be the future. This is the prospect guidelines. This is procedure-specific post-operative pain management recommendations. What they are telling is, for an adequate intraoperative and post-operative pain relief, the surgery is best done when it is done arthroscopically. Intraoperatively, you give paracetamol and NSAIDs along with the regional anesthesia block technique and use opioids for post-operative breakthrough pain. This is collecting all the data from 2006 to 2019, all the data that has been collected in terms of pain related to shoulder, and this is what they are suggesting right now. So what's the take-home message? So as far as shoulder is concerned, we need a good communication between the surgeon and the anesthesiologist. We need to know whether it is an open or arthroscopy, where you're going to put the incision, where you're going to put the ports, what position you're going to keep the patient, what is the rehabilitation plan, and close post-operative monitoring for complications. And what complications do you look for? Is number one, nerve injury. Number two, you need to know if the patient is having adequate pain relief, and in some cases there can be breathing difficulty. One, because of the phrenic nerve paralysis, and another, there can be a hemo or a pneumothorax. So always look closely for it. One word of caution will be, in the interscalene block, you will block out the C5, C6 and C7 nerves. But in case of the superior nerve trunk block, you will be only blocking out the C5 and C6. And as you know, the posterior aspect of the shoulder is mainly blocked by the supplied by C7 nerve. So there can be some amount of sparing. So if there is some amount of sparing, you can go in with local infiltration for your port and then proceed on with the surgery. These are my references. And this is a QR code. If anybody is interested in the slides, you can just scan it and download it into your phone. Thank you very much for the opportunity.
Thanks for that. You stay there. So when the questions are being asked, Sundar had to excuse himself to go to the operation theatre. However big surgeon you are only as good as the anesthesiologist. You know, if he is not so good, and your surgery not going to be so good. And gone are those days when the anesthesiologist used to say, the shoulder patient is not fit, I can't take it. Now they take all the cases because the block is available and the ultrasound machine is there, and really progressed as far as shoulder surgery is concerned. Now is the time for some questions and answers, the fundamentals. So please don't hesitate to ask questions. I also encourage the attendees to ask the questions. This is only one chance for the faculty.
Right. So I couldn't get your name.
Speak into the mic.
Siddharth. We routinely do all my shoulder surgery at my hospital with ultrasound guided interscalene blocks. And two questions at the same go. How difficult it is to give this superior trunk block? Number one. Number two, you have mentioned that there is the safety profile of liposomal bupivacaine is not established. What do you mean by that?
So basically, sir, first I'll answer the first question. The block is very easy to perform. So as I told, the technique was published by Dr. Ki Jin Chin in University of Toronto in Canada. It is basically, instead of giving the interscalene glue, you come a little bit down. You just need to identify the superior trunk and give it. He has actually uploaded a YouTube video where he explains the block per se and how he performs it. So it's very easy to do. The liposomal bupivacaine right now, the safety profile is good. The thing is, they just need approval. Number one, it is now FDA approved for only interscalene block. And right now, one of my consultants has gone to the UK where they even used liposomal bupivacaine for erector spinae plane block for cardiac surgery, where they do a sternotomy. The patient is extubated on the day of surgery and is eating with chest drains present. So it's excellent profile. It's also safe. But the main problem for us is the cost. 10 ml costing 35,000 is not adequate for us. So that's the main problem.
Thank you.
Thanks.
Yeah, any questions from attendees? How many minutes do we have, Shah?
We have another 2 more minutes.
Okay.
But live surgery is also, they have completed the surgery.
Oh, see, then we can
Yeah,
see it.
we will have a look at what's been done.
Is it recorded or live?
Live.
He hasn't come out yet.
Can you hear us, sir? Sujit, sir?
We can hear you. We have completed the supraspinatus. We have taken 6 bites. We have unloaded 1 anchor. So those are the sutures already tied on the supraspinatus. There are 6 sutures coming out. There was a dog ear. I have taken a dog ear bite as well. And that is the lateral end, where we are planning to attach our anchor. Can you hold the camera, please? So that is omega anchor. You came in the right moment. So we are going to, that is the trial reduction with the sutures, and that's the lateral part of the greater tuberosity. That's the biceps which is stenotomized you are seeing here. And here we are going to insert the omega anchor. It's a very good anchor. It takes up to 10 fiber wire limbs. So we got 6 here. We are going to insert all of them together into 1 omega in the lateral row because it is only the supraspinatus. If we have the infraspinatus long, I would have used probably 2 anchors to park the sutures in a box fashion. Can I have the first? Can you hold that for me?
Okay. So when you're doing eliciting the type of lateral row repair, I would like to ask, make use of the time and ask question to Dr. Murugan regarding his talk. Am I allowed to do that, sir?
Yeah, sure, please.
So just a layman's question. Orthopedic surgeon looking at an MRI scan for a suspicious rotator cuff tear, when do you say that MRI scan is worthless? You cannot rely on the scan, because most of the time we do see people treating the patient based on the report, not on the film. So when do you say that this MRI scan film is inadequate to diagnose the tear?
I think of late, with the advent of 1.5 Tesla, the average image quality has gone up more than 60% of the time. So as long as you see the tendon and insertion in the coronal and sagittal, and if you are convinced that the tendons are visualized well, I think one can make a safe interpretation from the given MRI. Of course, the standard may not be the same, but that is what I feel.
Sometimes they come with just 2 films.
Yes.
Sometimes even 1 film.
Yes.
And no CD. Usually the radiologist reads from the monitor and asks the technician to take the film. He takes whatever cut he wants and sends it across. So difficult for us to, we go on repeating them. Mercilessly we repeat the MRIs, because otherwise we'll be unnecessarily doing surgery on a patient for whom surgery is not indicated. You want to say something? Yeah. Yeah. Introduce yourself, please. Yeah.
I'm Dr. Rajiv Kulkarni. My question is to Dr. Murugan, sir. Sir, any thoughts on functional MRIs?
Yeah, unfortunately, in MRI, there is a big limitation, because once we position the patient inside, there is not much maneuverability you can do. Whereas ultrasound that way is really helpful. One can read it because that is a dynamic assessment of rotator cuff. an MRI, because of the closed bore, it is difficult. The maximum we can do is in different position. For example, for labrum, we use this external rotation study, ABR position. But otherwise, the dynamic assessment in MRI, of course, the newer generation open MRI is coming, but that is not, I don't have personal experience on that.
Okay. Thank you so much, sir.
So some more questions. Please don't hesitate to ask questions at the back. Babur, you want to ask something? Come.
As a continuing for the previous question. So, for example, we have a patient post-traumatic rotator cuff tear. We see indirect signs on X-ray, and we did ultrasound. So we see the cuff is torn, for example, supraspinatus. Is it enough for us to go straight forward to surgery? So, or MRI is must. Anyway, we will do scopy. Anyway, tactically, should we do or not?
Yeah, it's a part radiology, part surgical, I think. But from my experience, if it's an acute injury, and as long as it answer your question, whether the tear is there or not, many a time ultrasound is helpful just to confirm the diagnosis. Of course, if there's an additional tear of infraspinous and subscap, all those things probably you need to find out in scopy. That's a challenge. When you do MRI, you know you are 100% sure. What is your take on that?
What exactly is the question? Can you?
No, he's asking in acute cuff tears where there is clinical and X-ray based evidence of cuff tear. We are just supplementing ultrasound to check whether the rotator cuff is torn. Is it mandated for us to go for an MRI scan because we are going to scope the shoulder anyway?
I think yes, because it's not so costly, and very often the radiologist is not used to ultrasound, for shoulder at all, and MRI is not very costly.
I think the practice is
as far
different
as
there.
evidence-based medicine is concerned, you better do an MRI scan because post-operatively you want to quantify what was the muscle quality. It may be an acute tear, but it may be an acute on chronic situation. We don't know what's going on. So better to do a pre-op MRI, which is absolutely mandatory.
Can I ask the faculty, very often you get a patient with periarthritis and with an MRI saying, I come for surgery, supraspinal tear, because usually you find partial tear somewhere or other, or tendinosis, hardly any tear. And which is the actual indication for MRI when you see clinically periarthritis? Anybody?
So I think I will take this opportunity to talk to the youngsters in the group here. It's very, very common to have a diagnosis of partial tear of supraspinatus or a small full thickness tear of supraspinatus, etc., etc. But it is unlikely to diagnose of adhesive capsulates in the MRI scan because most of the radiologists are able to see the tendon, but they miss this rotator cuff interval thickening and therefore the axillary pouch thickening and all that in the MRI scan. So majority of times, patient with adhesive capsulitis will come to you with a diagnosis or MRI diagnosis of rotator cuff tear. So do not take MRI reports blindly unless it is given by somebody like Dr. Murugan. That's one important fact. And whenever in doubt, try to read the MRI by yourself. Whenever in doubt, talk to your radiologist again and again, or ask him to check the images again and give a report again. And then clinical examination is very important. Your MRI scan should correlate with clinical examination. Whatever the MRI scan says, somebody has a significant passive stiffness of the shoulder, that is frozen shoulder. This is not a rotator cuff tear. Even though a patient has a small, medium-sized supraspinal tear with severe stiffness, we tend to treat him more like a frozen shoulder rather than a rotator cuff tear.
Good, okay, thank you. What is the indication for MRI in your practice when patient comes with full-blown periarthritis?
Indication as such for MRI will be anyone we are planning for intervention, surgical intervention. I definitely do MRI in all those patients. With only ultrasound, I don't go for surgery because I want to find out any other pathologies are there. For example, like slap lesion, anything else can be there. So definitely we go for MRI.
What are the pathology you are talking about?
Any path. For example, like labral lesion can be there, slap lesion can be there, partial tear can be there, accruement size I want to see. So if anyone coming for surgery, definitely you need to go for MRI scan in my practice. Definitely.
Are you saying that all the periarthritis in your
not periarthritis
come for a surgery?
No, periarthritis coming for surgery. Yes.
I'm talking about periarthritis per se. The patient comes to you, your office, with an X-ray, clinically full-blown periarthritis, when do you ask for an MRI? Because a lot of patients come with MRI periarthritis from the periphery. Sir, I come for surgery. I believe there is a tear.
Usually you submit them for rehabilitation first when they come for the periarthritis.
So in your practice, no?
No.
Okay, anybody else?
Not immediately, no. Only at the later stage when they are not responding to your intervention, then you go for.
And the light of the Yes, Clement.
Yes, sir. The most important thing clinically, what we miss is simple test, external rotation with the arm by this side. So this is the first moment to go in frozen shoulder, periarthritis. So if you don't do that and you do the impingement test and other things, you can diagnose whatever you want in periarthritis. If you do the slap test, it will also be positive. The simple test, what you do is external rotation with the arm by this side. If it is stiff, it rules out all other diagnoses. And then the treatment of frozen shoulder also is kind of changed right now. I don't know what practice you do. In our practice, we go for an early injection, no physiotherapy. So physiotherapy worsens in the stage 1. So many times we give injection, that relieves the pain, then there is a slight improvement in the movement. Then we assess the weakness patterns. If there is external rotation weakness, maybe at the time we can ask for MRI. But most important thing is, a lot of surgeries are being done. I used to tell to my fellows, there is no MRI which, except from Clarity, Dr. Murugan, it says normal shoulder. There will always be a small cuff tear. And the knee also, there will always be a grade 1 meniscal tear. So there will never be a report. I have seen so many MRIs reported by you, normal knee, normal shoulder. That's what is missing nowadays.
That's a good message. Depend on your clinical diagnosis. Rely on your clinical skills before you jump on an MRI or anything else. Yes, sir.
I'm Dr. Mahesh from Thrissur.
Yes, Mahesh.
As Dr. Clement said, frozen shoulder is purely clinical, where the external rotation is predominantly and differentially involved. If you have any doubt in that, MRI is indicated, because cuff tear also is known to produce stiffness with more of internal rotation limitation. So if you have a predominant external rotation limitation where the primary pathology of involvement is interval, one can go without MRI. A frozen shoulder should respond to physio if it is uncomplicated, unassociated with any other structural problems. It should improve in 3 to 6 weeks. If it doesn't improve, you have to rethink about some other structural problem like SLAP, osteochondral injuries, upper subscap tear, which can produce something like an acquired frozen shoulder, in which scenario MRI is mandatory.
The history is very important here.
Yes, sir.
They give a history of fall and wait for 2-3 months, keep arm like this, and then present stiffness. Suresh.
In addition to all Clement and Mahesh said, I think a true AP X-ray and axillary is must. Even if you don't send for MRI, but X-ray is must, because I have diagnosed osteoarthritis, I have diagnosed secondary mets, infections. When patient was labeled as a frozen shoulder for months together, clinically it appeared frozen shoulder, and nobody had bothered to do even basic X-ray, and they were put on physiotherapy for months together.
Calcifications also. Many a time MRI just pure and simple misses calcification.
Chansey, give me a minute. Patient, Ethan, only one question for you, because I want the attendees to ask questions and interact. Manish is feeling very bad, nobody asked him a question.
Since Clement sir told about injection, I just want to know whether it's a good idea to take an MRI before doing an injection. Before a steroid injection, because I prefer to take an MRI if I am contemplating an injection. Before injection, no MRI. But shall we do an injection without MRI? That's my doubt.
Should I?
Sorry. Sir, I wanted to highlight that point, sir. In my practice, just starting off, so when the decision for MRI needs to be taken, I've started to give ultrasound guided, just local anesthetic injections into the joint or subacromial space. So now that will, after the injection, in about matter of 5 minutes, we can do the reassessment. And if the pain is taken off, examine again. If there is weakness, there's cuff tear, go for an MRI. If no weakness, then it's an adhesive capsulitis. Now, as the injection will act as a contrast, the injection will so we get an MR arthrography, and it will be beneficial. Apart from history, clinical, now the additional tool is ultrasonic. Just no need to give steroid also, because steroid can propagate. Just give a bupivacaine or a lignocaine. It gives us more information as to whether this is a weakness problem or a stiffness problem. because the pain is taken off.
Right here onto the suture limb, that's all. So it's holding this part.
Thanks, Manish. Sujit, we are with you now.
Hello, yes, we have completed our repair, supraspinatus. That's the supraspinatus with 3 suture limbs, 1, 2 and 3. So that's the last knot is somewhere posterior here. There's the middle one and the anterior. And that's the lateral row anchor parked here. You can see the omega parked here. So omega is a beautiful anchor which can take up to 10 suture limbs. And that is the compression you have onto the footprint.
Thanks, Sujit. That's an excellent
That's the supraspinatus
surgical
here.
demo. There's a big applause from the hall here.
Thank you.
And
Thank
you
you.
not only
Thank you, sir.
showed us how to do it, but also you showed us what kind of difficulties you come across while performing this surgery. We
Yes.
all benefited from it. Thank you very much.
Thank you.
The vision was a little difficult.
So we can
inside.
wind up.
Thank you, sir. We
this
can wind
session.
up.
So I thank Dr.
team
Murugan, Dr. Muniz, and Siddharth. Thank you very much. Over to Dr. Shah.